Hello everyone and big thank you for joining us today. I am Saxena along with my colleague Dr. Deepika Chabra from Medical Services on behalf of Jagsonpal Pharmaceuticals Ltd would like to extend warm welcome to all the attendees and faculty today to this scientific Sangam 24 organized by ISOPARB Prayagraj in association with Allahabad and Northern India Obst and Gynae societies with academic partner Jagsonpal Pharmaceuticals Ltd, makers of Divatrone, Maintane, injections, and Verena. This webinar is granted 2 ICOG points. Jagsonpal would like to thank the experts and participants for joining us today through this webinar. Jagsonpal are delighted to introduce Divatrone 10 mg tablet, fully indigenized, micronized dydrogesterone, the only brand with having 36 months of shelf life. Scientific Servant 24, the art and science of birthing wife, organized by ISOPARB Prayagraj, organizing chairperson Dr. Ranjana Khanna ma'am. Ma'am is founder president ISOPARB Prayagraj. She is also the ICOG governing council member and vice president FOGSI 2017. Now I request my Dr. Ranjana Khanna ma'am to kindly initiate this session.
A very good evening, everyone. At the outset, before we start anything, we always fold our hands in prayer to Lord Shiva. A very good evening, everyone. Today, I welcome all my friends from Chandigarh who have joined us. A big welcome to all of you, and it's a real pleasure. So it's connecting of 2 North Indian societies, and I would like to welcome today. It's actually a privilege to have with us the very illustrious and dynamic president-elect of FOGSI, Dr. Jaydeep Tank. And as we know that he has climbed up the FOGSI ladder in the step ladder pattern, and I think dedicated so many years to our federation, which is so much loved by one and all. I think, if I am correct, you started as a joint treasurer, then deputy secretary general and secretary general. So, and now truly deserving president-elect of FOGSI. And as everyone knows that he is the person who has introduced electronic voting in FOGSI. Dr. Jaydeep Tank, he is the project lead FOGSI USA projects and past president Mumbai Obs and Gynae Society. And he is the deputy secretary Asia Oceania Federation of Obs and Gynae. Immediate past chair International Federation of Obs and Gynae Committee for Safe Abortion, awarded the FRCOG honorary causa in 2020 by the Royal College of Obs and Gynae, and past chair Publication and Newsletter Committee AOFOG past chair Reproductive Endocrinology and Infertility Committee AOFOG, past chair MTP Committee FOGSI, and he is currently consultant in Ashwini Maternity and Surgical Hospital Center for Endoscopy and IVF. So welcome, Dr. Jaydeep, and we would love to hear from you, whatever you have to say, and please bless our webinar.
Thank you very much, madam, for having me here. It's a pleasure and a privilege, I must say, to be here. Congratulations to you, Dr. Ranjana Khanna, madam. I've known madam since I don't know how many years now. It's been the longest time. And she's always a smiling, very nice, and very highly academic personality. So congratulations, madam, for putting this wonderful webinar together, along with your organizing secretary, Amita Tripathi, again, someone I have known for quite really the longest time. And of course, your co-convener, Dr. Jaiswal, Dr. Parul Khanna will moderate the Q&A, and we have best wishes from Dr. Shubha Pandey and Dr. Meenakshi. And Madam, I must congratulate you on your choice of speakers, such eminent faculty, yourself, of course, and Dr. Muralidhar Pai, I can see sir here. And I've always said this, when you add Dr. Pai to a webinar, you add around 20 to 40% attendance also to that webinar. Always a pleasure and a privilege listening to sir. And of course, Dr. Bharti Joshi from Chandigarh, and very eminent chairpersons also, Madam. Dr. Reeti, Dr. Manisha, Dr. Lalita Shukla, Madam, Dr. Saha, Dr. Ritu Sinha, and Dr. Pooja Sikka. And of course, very, very important topics on liker issues, emergency during birthing with amniotic fluid embolism, something where I think there is a playing field, if I may say so, because whether you have an amniotic fluid embolism in any country of the world, outcomes are uniformly not that great. And then, of course, the role of routine episiotomy, something which, I have some friends who don't believe in episiotomies. They say, let there be a tear and I'll prefer to suture it and all. I'm not one of those. I'm a votary for episiotomies frequently, as often as required. And I'm sure that Dr. Bharti Joshi will focus on that also. So thank you again, madam, for inviting me. I must, mention Dr. Deepika Chhabra here. I have seen Dr. Deepika Chhabra in so many webinars during the COVID pandemic. And then finally, I think I had the pleasure of meeting her in Varanasi some time back. So I think congratulations, Dr. Deepika. You've been a consistent.
Yes, sir. Thank you so much.
Yeah, she's actually very dynamic.
So, thank you very much, madam. It's a real pleasure and privilege. Thank you.
Thank you so much, Dr. Tanks. Thank you so much for coming and boosting our morale. And yes, these currently I'm doing these series of obstetric webinars, and I keep on and on troubling Dr. Muralidhar Pai off and on.
A very good evening to all of you. And first of all, I would like to thank Dr. Jaydeep Tank for his kind words. Now, we begin with our fifth session of Art and Science of Birthing. And when we speak about birthing, one of the important issues we deal is with amniotic fluid. Either ways, when it is too much or too less. And to address this issue today, we have our first speaker, Dr. Ranjana Khanna ma'am, founder president of ISOPARB Prayagraj. And I would like to invite the chairpersons now. Our first chairperson is Dr. Reeti Mehra ma'am. She is a professor in Obst Gynae at GMC Chandigarh. She has been president of Chandigarh region of Menopausal Society, joint secretary, North Zone Obst and Gynae Society, North India. Ma'am has been awarded Rashtriya Gaurav Award and Endoscopy Fellowship in Germany. Ma'am is member editorial board of JMH, and she has more than 60 publications in national and international journals and has authored around 15 chapters in various books. Her special interests are minimally invasive surgery, menopause, and high-risk pregnancy. I welcome you, ma'am. Our second chairperson is Dr. Manisha Goyal. Ma'am is private practitioner in Allahabad. She is director of Shikhar Hospital, life member of IMA and FOGSI, and member of ISOPARB Prayagraj. I welcome you, ma'am. Now I request Dr. Manisha Goyal to introduce our speaker, Dr. Ranjana Khanna ma'am, and Dr. Reeti Mehra to give expert comments thereafter. Over to you, ma'am.
Thank you, Parul. Dr. Ranjana Khanna madam, the stalwart of Prayagraj, need no introduction. She is a famous personality, not among the doctors, but also among the common people. And she is a senior consultant and director, Ranjana Hospital, Prayagraj. She has been National Vice President, FOGSI 2017, Founder President, Prayagraj Chapter of ISOPARB 2021-2023, ICOG Governing Council Member 2021-23. She has been President AOGS Allahabad 2013 to 2016, Honorary Secretary AOGS 2011 to 2012, and Treasurer AOGS 2008 to 2010. She is organizing chairperson in various national FOGSI conferences like Obstetrical Dilemmas, BOH, and SEVMA. Faculty at various national and international conferences and webinars. And she has awarded many national awards like FOGSI Dhira Award, FOGSI DK Chang Reproductive Healthcare Promotion Trophy, and FOGSI Smriti Malin Award. We welcome you, ma'am.
Thank you so much for the wonderful introduction, and welcome, Dr. Pai. I'm more eager to listen to you than to give my talk. Good evening, everyone. I'll be speaking on liquor issues in birthing. We all know that amniotic fluid is the clear yellowish fluid mainly derived from baby's urine. Liquor serves many purposes for the betterment and protection of the unborn child. Because of its importance, several issues may arise if the amount of amniotic fluid is not correct. That is, too much or too less. This is a picture showing that. Now, the physiology of amniotic fluid. Early pregnancy, composition of amniotic fluid is similar to extracellular fluid and is produced by transfer of water across the amnion and through the fetal skin. By the second trimester, the fetus begins to urinate, swallow, and inspire amniotic fluid. During the last two-thirds of pregnancy, the amniotic fluid principally comprises of fetal urine. The amniotic fluid volume rises linearly from early gestation up to 32 weeks. After that, it remains constant in the range of 700 to 800 ml until term. At 40 weeks of gestation, the volume starts declining at the rate of 8% per week. And by 42 weeks, the volume decreases to approximately 400 ml. Now, this is, we can see 16 weeks, it's 200 ml. 28 weeks, it's 1000 ml. 40 weeks, it is 800 ml. And after that, 42 weeks, it becomes 400 ml. Amniotic fluid serves the following purposes. Provides a cushion to protect the child from trauma. Keeps the umbilical cord from being compressed and reducing the oxygen supply to the baby. It creates a physical space for fetal skeleton to shape normally, prevents infection, and helps to keep a regulated temperature in the womb. How do we measure the amniotic fluid? The amount of amniotic fluid is measured either by checking the largest vertical pocket of fluid by ultrasound or measuring the vertical depths of amniotic fluid pocket in each of the 4 quadrants, then adding those up. This is called the AFI or amniotic fluid index. Because the AFI has too many false positive rates, the single pocket amniotic fluid evaluation has recently been found to be more reliable than the AFI. Now coming to too much liquor, this is also known as hydroamnios or polyhydroamnios. It is defined as AFI more than 24 centimeters and the single deepest pocket more than 8 centimeters. Incidence is 1 to 3.5% of all pregnancies. The degrees could be mild, moderate, severe. Mild is 8 to 11 centimeters of single deepest pocket. Moderate is 12 to 15 and severe is 16 centimeters or more. This is a picture showing the polyhydroamnios. Causes. Idiopathic in 50% of cases. The role of aquaparins has gained attention. Water channel aquaporin 1 expression was found to be increased in amniotic membrane of those pregnancies which were complicated by idiopathic hydroamnios. Fetal anomalies like congenital anomalies, there are basically two factors which cause the polyhydroamnios, either excess of urine production or decreased absorption or decreased swallowing of the urine by the fetus. So congenital anomalies like anencephaly, open spina bifida, esophageal or duodenal atresia, cleft lip, cleft palate, fetal anemia as in infection, or RH incompatibility. High output cardiac states like hemolytic anemia, parvovirus B19 infection can increase the fetal urine output. Aneuploidies, trisomy 21, that is Down syndrome, 18 Edwards syndrome, 13 Patau syndrome, can be also associated with hydroamnios. There is a Bartter syndrome, which is a rare autosomal recessive disorder affecting fetal renal tubular functions leading to hydroamnios. Maternal causes, diabetes mellitus in 30% cases. In this, there is increased maternal blood sugar. We all know it leads to increased fetal blood sugar, leading to fetal macrosomia. And because the baby is so big, so more of urine and fetal diuresis. Cardiac or renal disease may lead to edema of the placenta, causing increase in transudation, multiple gestation, especially in uniovular twins, usually affecting the recipient twin in twin-twin transfusion syndrome. Placental causes like chorioangioma of the placenta. There are two types clinically. One is the chronic, onset is insidious, taking few weeks. Acute, which is rare, onset is sudden within few days or may appear acutely on pre-existing chronic variety. Complications, antenatal period, preterm labor, PPROM, then it could be malpresentations, abruptio placentae. During labor, uterine dysfunctions, cord prolapse, PPH, operative interventions are more prevalent. Puerperium, increased morbidity due to infection and subinvolution. What are the signs and symptoms? There could be dyspnea, abdominal pain, varicosity of legs, vulva, hemorrhoids, edema of legs, contractions leading to preterm labor, decreased perception of fetal movements. How do we manage? It depends on the severity of the condition. Minor degree usually requires no treatment except extra rest for a few days. Severe degree, we have to relieve the symptoms and correct the underlying etiology. So there comes the role of therapeutic amniocentesis or amnioreduction as we call it, and prostaglandin synthetase inhibitors. Now, how do we manage a case which comes, a scheme of management will be, we hospitalize the patient, do the necessary investigations, PPBS, GTT, HbA1c, serology for all the infections, including the torch infections, red cell antibodies, ABO-RH, targeted ultrasound for fetal anomalies and genetic syndromes, and this is very important. And now, if we do not find any fetal abnormality and the patient is responsive to treatment, though transient, continue the pregnancy, manage the complications if any, and deliver at term. And at the time of delivery to guard against PPH, thorough neonatal examination to exclude malformations is very important after delivery. Now, if the maternal distress is too much and it is persistent, if the patient is less than 37 weeks, then amnioreduction is done, which can be repeated again till fetal maturity. If the pregnancy is already at 38 weeks, amnioreduction is done. Correct the lie if by external cephalic version, stabilize and start the oxytocin drip, and you can do a controlled ARM and deliver the patient normally. Now, if fetal abnormality is found, refer to a maternal fetal medicine unit. Pregnancy termination or delivery is the option, cervical ripening ARM, and then deliver. Now, when we talk about amnioreduction, it is recommended only in cases with severe polyhydramnios for relief of maternal symptoms like abdominal discomfort, dyspnea, or preterm labor. The fluid should be removed no faster than 500 ml in 1 hour and maximum up to 1 to 1.5 liters, as there is increased risk of abruption. If you abruptly remove the fluid, then chances of placental abruption are there. So this has to be done very carefully and under ultrasound guidance. Procedure is stopped when the AFI is within the normal range. This picture is showing amniocentesis, which is normally done for diagnostic purposes. And in this, needle is inserted, of course, under ultrasound sound guidance. We have to be very sure we are not putting the needle through the placenta. Take out the fluid and send it for analysis to be sure that there are no congenital defects in the fetus. Prostaglandin synthetase inhibitor, indomethacin, decreases urine production from fetal kidneys, also production of lung fluid. The dose is 25 milligrams 6 hourly, up to 75 milligrams 12 hourly, orally or rectally. It is to be given for gestational age less than 32 weeks, as treatment thereafter may lead to premature closure of patent ductus arteriosus. AFI is to be assessed 2 to 3 times per week, and treatment is stopped if the AFI is within the normal range. Side effects of indomethacin could be fetal hyperbilirubinemia, necrotizing enterocolitis, intraventricular hemorrhage, or oligohydramnios. Now we'll talk about oligo, that is the Likert becoming too less. Affects 4% of pregnant women, commonest in last 3 months of pregnancy. This incidence increases in females who are post-mature. We've just said that at 42 weeks, the Likert decreases up to 400 ml. Oligohydramnios can be defined in 4 ways. AFI less than 5 centimeters, AFI less than 5% for a specific gestational age, and single deepest pocket less than 2 centimeters. The incidence is 3.9% of all pregnancies, and 12% of women who go to 2 weeks past their due date have this condition. This is a picture showing oligoamnios. Now, what are the causes of oligohydramnios? Maternal causes. Uteroplacental insufficiency. Oligohydramnios has most consistent association with fetal growth retardation, which has fetal hypoxia, causes redistribution of cardiac output to the fetal brain from the kidneys and lungs. So reduced fetal urinary production and decreased lung secretions, leading to oligohydramnios. Preeclampsia, hypertension, diabetes mellitus, drugs like indomethacin, sulindac, ACE inhibitors, dehydration. Fetal causes could be ruptured membranes, postdatism, fetal anomalies. There could be congenital anomalies like renal agenesis. This is there in 57% of the cases. Other anomalies includes Fallots tetralogy, septal defects in 15 to 20% of cases, and chromosomal anomalies. Placental causes could be abruption and twin-to-twin transfer. Now, complications. In the fetus, there could be abortion, pulmonary hypoplasia seen in around 15% of cases. The risk of pulmonary hypoplasia increases as the gestational age decreases, at which the membranes rupture. Fetal deformities associated with additions between amnion and the fetal parts may cause serious deformities like clubfoot, wry neck, or even amputation of limbs. Cord compression leading to increased risk of variable heart rate decelerations, fetal distress, low Apgar score, and high risk of fetal mortality. What are the complications in the mother? Prolonged labor due to inertia, increased operative interference due to malpresentations, and increased morbidity. Now, we have this baby in this, there is oligohydramnios. So there is hydronephrosis. There could be clubfoot, enlarged bladder, enlarged kidney, and small lungs. Investigations. Detailed examination of the fetal anatomy, particularly the renal tract, must be done. Non-stress tests must be performed weekly until delivery. Doppler velocimetry of umbilical artery must be performed and SD ratio recorded. An increased SD ratio helps to identify fetuses at risk of low birth weight or PIH. How do we manage? Management depends on associated pregnancy complications and on the gestational age. When remote from term, endeavor is to prolong the pregnancy with close fetal monitoring. Nearer term, pregnancy termination is planned at 37 weeks with membranes intact if the fetus is at risk of adverse perinatal outcome shown by abnormal Doppler studies or IUGR. Now, when we talk about maternal hydration, because one of the causes we have said is dehydration, maternal dehydration. Maternal hydration, oral or IV, has been shown to increase amniotic fluid index in some studies. Cochrane review in 2002 included 2 RCTs. In these studies, women were asked to drink 2 liters of water before repeating ultrasound. AFI was found to be increased both in women with or without oligo. Veggies like cucumber, cauliflower, spinach, and fruits like watermelon, grapefruit, tomatoes are said to increase the amniotic fluid levels. One of the well-known benefits of coconut water during pregnancy is increased amniotic fluid levels. In 3rd trimester, intake of tender coconut water helps to improve the AFI according to some studies. Amino acid infusion. IV infusion of large amount of 10% fructodex amino acids and antioxidants have been tried. The improvement in AFI by IV amino acid infusion acts by improvement in maternal nutritional status. Now, role of L-arginine. L-arginine supplementation is promising in improving volume of amniotic fluid in cases of oligohydramnios. It acts by increasing the bioavailability of endothelial nitric oxide, thus improving the umbilical artery blood flow in the pregnant woman. In a study, 100 pregnant women with oligohydramnios took 3 gram sachets of L-arginine TDS till an increase in amniotic fluid occurred. Now, what is the role of amnio infusion in modern obstetrics? We are very guarded about the role of amnio infusion in modern obstetrics. Initially, a lot of hype was created over amnio infusion, but now a lot of studies have been done and no particular benefit has been seen by doing an amnio infusion. So currently in modern obstetrics, its role is very guarded. Of course, if during labor in the second stage of, during the first stage of labor in the active phase, if it is a multi 6-7 centimeters dilatation, cervix is thinned out, suddenly the membranes rupture and thick meconium comes out. And then when you hear the record, the fetal heart, you see variable decelerations. That means that the fetal head is compressing on the cord. So in that case, in some institutions, they do resort to giving amnio infusion by putting in a catheter and injecting some ringer lactate, which is slightly warmed, and or normal saline. And that reduces the compression of the umbilical cord. It is said to improve fetal outcome, but then not much is known about it. So we can only give a guarded review about this. And there could be one problem of amniotic fluid embolism in these cases. Recent studies suggest that isolated oligo may occur in late pregnancy in patients with no other high-risk factors, and reassuring fetal heart rate pattern does not justify induction of labor. Induction of labor results in increased chances of operative delivery or cesarean with no difference in neonatal outcomes. So, to conclude the take-home messages, minor degree polyhydramnios requires no treatment. Moderate degree with some discomfort can be managed without intervention. Severe degree, if dyspnea or abdominal pain, hospitalize the patient. Bed rest, diuretics, salt restriction, absolutely ineffective. Amniocentesis is transiently successful in relieving maternal distress in severe hydramnios. Fetal outcome is poorer with early onset oligohydramnios. Management of oligo in late pregnancy depends on clinical situation. Expectant management till term can be done if detected before 36 weeks. L-arginine could be a potent treatment option for oligohydramnios, but again, we are very guarded about this also. Some studies recommend increasing intake of water as proving helpful in increasing amniotic fluid levels. Thank you so much. And we are hosting the National FOGSI Conference Scientific Sangam 15, 16, 17 December at Prayagraj. So Allahabad, the Obstetric and Gynecological Society is welcoming all of you to this Kumbh of Knowledge, in which we have Ganga as the obstetrics, and Yamuna as the gynecology, and Saraswati infertility, and besides that a host of other super specialities will be looked into. So welcome all to this scientific Sangam. Thank you all so much for this patient hearing.
Wonderful talk, Dr. Ranjana. It's really nice. Full Sangam of you've not left any point untouched. And yes, liquor is very, very important. Both increased liquor and decreased liquor are a source of tension to the obstetrician. And I'd just like to say one thing, that yes, extra rest in the afternoon, starting of aspirin in high-risk patients at an early gestation, arginine in patients who arginine or amino acids in patients who have, a poor nutrition does help. And especially where patients are at a high risk of developing IUGR, gestosis score can be calculated, and increase and start of aspirin early has been shown to improve the liquor output by improving function. The other comment about the amnio infusion, about amnio infusion, that I'd like to say is they used to feel that it reduces the meconium aspiration syndrome if you're diluting the meconium. But it has been seen that the baby already has thick meconium in the vocal cord. So amnio infusion has not shown to improve any results if we are doing amnio infusion for meconium stained liquor. The only thing that there are sporadic reports are if there has been absolute drainage of liquor in a patient who's very preterm, say 25, 26, your nursery is not able to take care of a 25-weeker, and the baby is very, very precious. There are isolated reports where amnio infusion can be done just to give the liquor for a bit more time and continue as an experimental procedure, completely as an experimental procedure, to take it to at least the period of or give it maybe a week or more, and these are just isolated reports. For meconium aspiration, it has not been shown to be useful.
Yeah.
So with
Dr. Pai, what is your say on amnio infusion?
No, luckily, before we tried it, it has been not approved by most of the obstetricians. So we didn't venture to try. As Madam, earlier Madam was telling, Dr. Reeti Madam was telling, amniotic fluid is not a stagnant water there. The infusion has got its own, problems. And more importantly, as Dr. Reeti Madam said, whatever damage has to occur has already happened. You are only trying to make a cosmetic change there. And it has got a more dangerous problem, which I'm going to talk about next. As it can cause.
I mentioned it. I mentioned it, that it could lead to amniotic fluid embolism.
Yeah, I was carefully listening to you. So it does more harm than good. Rather, we deliver these babies by other means and give a safer baby as well as mother than venturing to this kind of thing. Even before delivery in early pregnancy also, whatever amnio infusion you do is not going to stay there. It's going to be absorbed, and unless there is production, there is no way we can manage it. Yes, these arginines and other things have been tried because they have some vasodilatory effect, so they may slightly improve, but best thing is to deliver them in a safer environment at the safer time.
Yes. So anything else, Reeti, from you?
Absolutely wonderful listening to you, Dr. Ranjana. Fantastic. Everything is very well covered. Very, very academic.
Thank you so much.
Thank you, ma'am, for such an elaborate and complete talk, and Dr. Reeti ma'am and Pai sir for their valuable comments. I now hand over the session to Dr. Amita Tripathi.
Thank you, dear Parul. And we are moving towards the second session, which is very important topic. And the speaker is again a hot favorite in ISOPARB Prayagraj. Next topic is the amniotic fluid embolism, that is catastrophic emergency during birthing. And to chair the session, we have Dr. Lalita Shukla ma'am. She has been past president, Allahabad Obstetrics and Gynecological Society in 2021-22, She's ex-chairperson, Women Wings of Allahabad Medical Association. She is director of Arogya Niketan Prayagraj, and she's a wonderful human being and a fitness enthusiast. Welcome, ma'am. Unfortunately, Dr. S.C. Saha will not be joining us because of some grievance at home. So I would request Dr. Lalita Shukla to kindly introduce our speaker for today, Dr. Madhidha Pai, sir.
Good evening. Now, amniotic fluid embolism, as we all know, is one of the most catastrophic complications of pregnancy, with a very high mortality and long-term complications in the survivors. It involves a multidisciplinary approach. Today, we have a very well-known and favorite speaker, as Dr. Ranjana said, Dr. Muralidhar Pai. I have the pleasure of introducing him. He is the Dean of Sikkim Manipal Institute of Medical Sciences, Sikkim. He is the Professor of Obstetrics and Gynecology. He has 35 years of academics experience, 20 awards, 15 international fellowships, 200 plus publications, 2 textbooks, 700 guest lectures to his credit. Welcome, Dr. Pai. We are waiting to hear you.
Thank you, ma'am. It's a really a great honor and privilege to again and again interact with the members of Prayagraj Society. Thank you very much for your love and affection, especially that of Dr. Ranjana Khanna, ma'am. I just cannot refuse. I have to keep all other things aside whenever madam invites me. So I will now share my. So this is not a question of whether less like her or more like her. It is a problem of like her in the wrong place. So it is either in the lungs or it is entered the cardiovascular compartment, and that creates the havoc. As the person who introduced me said, it's such a catastrophe that doctors cannot explain. And even if we try to explain, the patients cannot accept, and it comes like a rude shock, bolt from the blue, and we will all be wondering. One disclaimer before I continue is that I think after my lecture, we will be very scared to conduct normal obstetrics because amniotic fluid embolism can occur even after a normal delivery. We simply do not know why amniotic fluid embolism does not occur in women. I would put it that way, because the things that I'm going to explain can occur in every single lady that enters the labor room. And thank God that only very, very few of them will have this tragic event of amniotic fluid embolism. So with that as an introduction and setting the tone of the talk, let me explain that. As I said, it's a very rare condition, thankfully, and it is unique to obstetrics. Obviously, you don't find amniotic fluid anywhere else but in obstetrics. And then it was first described in 1941 by Steiner and Losper. Now, you may wonder, what is the point in describing this if the mortality is almost 100%? In my subsequent slide, you will see that if the patient survives, then the diagnosis of amniotic fluid embolism is ruled out. Then what is the point in describing it and diagnosing it if we cannot, revive or save the patient? It is important to at least know the cause of sudden unexplained, so-called unexplained death in a laboring woman. And that particular confirmation may save us from the litigations and other things, though we cannot replace the irreplaceable loss that the family goes through. But at least people may understand that, yes, this was something which an obstetrician could not help at all. The 3 classical features of amniotic fluid embolism are, number 1, of course, it's an abrupt onset of severe hypotension, severe hypoxia, and consumptive coagulopathy. That means there is severe clotting, and because of that, there are no more coagulation factors. That's why there will be severe bleeding after this. So I have made my own acronym for easy remembrance. Like water, we say H2O. Here, I would put an acronym as H2C. Hypotension, hypoxia, and consumptive coagulopathy. Now, the thing is, there can be great individual variation in its clinical manifestation. Not all patients will have this classic triad of hypotension, hypoxia, and consumptive coagulopathy. Some patients may simply present as DIC with severe hemorrhage. It may be actually amniotic fluid embolism, nothing to do with atonic PPH or traumatic PPH, or these two may be the hidden cause of amniotic fluid embolism, but ultimate cause of death in the patient is amniotic fluid embolism, which gives rise to consumptive coagulopathy. It may present to us like a case of simple postpartum hemorrhage. Other thing is, only one of the three classical features may be predominant in a given woman. Maybe you will see only hypertension in a lady, or only hypoxia, or only coagulopathy. So both the sentences say that the classical picture or classical triad may not be seen in all women. The incidence, again and again, I'm telling, thankfully, it is very, very rare, 2 to 7 per 100,000 births, but for that particular family, it is 100%. If they lose a woman, it is 100% for them. But if you look at 100,000 births, it is very rare. That's what I said. Every single patient can have a potential for amniotic fluid embolism, but it does not occur. It is associated with high mortality. That's what I said. In fact, the textbooks mention if the patient survives amniotic fluid embolism, that means the diagnosis was wrong, which indirectly means the mortality is almost 100% if there is amniotic fluid embolism, unless it is of a very mild variety, or if there was a very early recognition and intervention. That's where my talk becomes important. How to recognize this early, who are the high-risk patients, and how early and what can be the intervention is the crux of my talk. The predisposing factors are, number one, rapid labor or a precipitate labor. Because here, things will occur so fast that there is a lot of hemodynamic changes occurring in no time, and there is a chance of that escape of the amniotic fluid and the debris into the circulation. Now, it's not just the rapid and precipitate labor, a prolonged labor also can predispose to amniotic fluid embolism. So we are now caught in between. So neither fast nor slow labor. Like always we say, anything extreme is not good. Meconium stained amniotic fluid is the biggest culprit or predisposing factor, because it is the meconium, if it escapes into the open sinuses, that will cause more harm to the mother as well as to the baby, rather than just the amniotic fluid. How does it escape into the circulation or into the pulmonary circulation? It is through the tears in the uterine and other large vein, pelvic veins. In fact, in every single delivery, when the placenta separates, there are open sinuses. But again, thankfully, nothing enters into them. Even if they enter, they are not of significant amount and quantity. That's why every delivery, instead of going into amniotic fluid embolism, it is thankfully not happening. The other risk factors are elderly age. These are some typical risk factors for any problems in obstetrics, obese patients, and medical disorders. It may be GDM, anemia, or heart disease, and then eclampsia, which is our usual problem, and placental abruption or previa. Again, here, whenever there is abruption, there is collection of the fluid, blood behind, and along with the breach, there can be escape of the amniotic fluid. Polyhydramnios, as madam was suggesting, oligohydramnios when you try amnio infusion, or polyhydramnios, they can both escape into the maternal circulation. And finally, post-term pregnancy. The labor induction or augmentation with ARM, especially in polyhydramnios, is a biggest risk factor. Now, having said that, we cannot say we will never induce a patient. We have to do this. And sometimes in order to find out whether if there is a fetal distress, we may have to do an artificial rupture of membrane to find out whether there is actually meconium staining, or sometimes if the labor is not going on track, then ARM is one of the methods of augmentation of labor. Now, whatever it is, they have a risk of amniotic fluid embolism. Can we prevent this? Of course, it is very difficult to say because there are no special techniques of ARM as such. Of course, in polyhydramnios, we say a slow draining of the amniotic fluid has to be done. Instead of going for the low rupture with the Cocker's forceps, it is better we go with the fine needle or lumbar puncture needle and drain the fluid very slowly. That's the only thing that we can do. The second one is injudicious use of oxytocin for augmentation. The severe contractions of the uterus can drive some of the fetal squame and the amniotic fluid into the circulation, maternal circulation. Obstructed labor. Obviously, in obstructed labor, as you know, the uterus is contracting its level best to overcome the mechanical obstruction. So that is the one which causes the amniotic fluid embolism. And finally, cesarean section. As you know, in cesarean section, it's all open. In every single case, I'm sure some amount of air enters into the open sinuses. The uterus is open, the interior of the uterus is open. And there is a big chance of amniotic fluid embolism or even air embolism in cesarean section cases. So everywhere, a meticulousness probably is the way we can handle. If you rush into the things, then there can be chance of amniotic fluid embolism. It's not only after normal delivery, it can happen even during cesarean section. But thankfully, in cesarean section, patient is under the control of anesthetist in case they want any intubation, in case they want to give any inotropic agents or oxygenation or fluid, they can immediately take care of that. That is the one advantage that we have at the time of cesarean delivery. Forceps and vacuum delivery, again, it is some amount of intervention there, and that can cause amniotic fluid embolism. So if you see the list in 2 slides, almost anything and everything can cause amniotic fluid embolism. We have to be very careful about every procedure that we undertake. Etiopathogenesis, it is not uncommon, as I said, for some amount of amniotic fluid to enter the maternal circulation, especially at the time of normal delivery. Through the open sinuses, they are always there whenever there is placental separation, because we know human placenta is hemo placenta. That's why there is severing of the vessels that are connecting, and sinuses are always open. And or a minor breach in the physiological barrier between maternal and fetal compartments. So always there is some escape of the amniotic fluid or even air for that matter. Squames and other cellular elements of fetal origin and trophoblasts are also identified in maternal peripheral blood at the time of delivery. So this happens in almost 100% of the women. Only thing is we don't go and check in every single lady. They are usually innocuous. As I said, if the quantity is not more, it goes unnoticed. But in some, amniotic fluid constituents initiate a complex series of pathophysiological sequelae such as hypotension, cyanosis, pulmonary edema, and dyspnea. ARDS, that is going to be very dangerous, adult respiratory distress syndrome. And cardiopulmonary arrest is the final common pathway before the woman dies. Then there is severe coagulopathy if she survives the initial onslaught. Some women also have seizures. The wide range of clinical manifestations may lead to variation or delay. As I said, some women may simply have hypotension, not other things. Some women may simply have air hunger. Some women may have just bleeding. So that's why we get confused whether it's a case of amniotic fluid embolism at all. That's why my request is that whatever it is, we should go with the idea, if there's any deviation from the normal in a lady, we should keep amniotic fluid embolism in the back of our mind. Of course, I'm not scaring anybody. I'm not saying you be always biased, but just keep a possibility of amniotic fluid embolism in the mind. That itself will alert us to be careful and to be on our toes, and at least not to neglect anybody. That's why I wonder sometimes when we leave the deliveries on the junior most doctors, interns, and sometimes postgraduates. Of course, they do not mean any harm to the patient, but they may not be simply aware of all these facts. Because we don't see amniotic fluid embolism every day. It's a rarity. But that's the reason they may not be aware of these situations. They may not be able to recognize the early cases. And each case varies, as I said. So that's why there is a delay in the accurate diagnosis in many. Amniotic fluid and its constituents have different actions on cardiovascular and coagulation system. So it depends upon whether these constituents have reached the cardiovascular system to the extent, or whether they simply create coagulation problems. Endothelin 1, which is one of the constituents expressed in fetal squamous, and phosphatidylserine expressed in the amnion, and complement activators, they incite anaphylactoid reaction, which is typical of like hypertension and sudden cardiac arrest. These things can happen like anaphylactic reaction. Whereas the tissue factor in the fluid incites coagulation. So in a given lady, both may happen or one of them may happen. So we have to be very careful. Whatever it is, the reason behind that is an amniotic fluid and its constituents. That much awareness we all should have. Fetal debris embolization and toxicity increase with the volume of amniotic fluid. That's what I have been telling right from the beginning. Some amount of amniotic fluid going into the circulation may not cause any problem. But as the volume increases, which may be because of polyhydramnios, which may be because of strong contractions, which may be because of a quick delivery or a prolonged labor or a sinus kept open for a long time, they will cause the problem. The amount of meconium contamination also is another factor. So that's exactly why if there is meconium, thick meconium stained liquor, better not to delay the delivery. And a mild meconium or a slight meconium may not cause much problems, but if it is a thick meconium, that's the best recipe for amniotic fluid embolism. Initial phase, there is pulmonary and systemic hypertension. You may wonder, all this while I was telling classic triad is hypotension and hypoxia, but in the initial phase, there may be hypertension and profound oxygen desaturation, the cause of neurological injury in most survivors. But the initial phase slowly goes into the second phase. Before that, there will be right ventricle acarism or dilatation, and left ventricular cavity is obliterated due to vigorous contractions. Heart is trying its level best to supply, but it may go into fibrillation. That's the cause of sudden cardiac arrest as well. Failure to transfer blood from right to left heart because of severe and unrelenting pulmonary vasoconstriction. So you have seen that endothelins and other components that can create the problems, and that's why there can be failure to transfer blood from right to left heart. The initial phase is followed by decreased systemic vascular resistance, leading to severe hypotension. So don't get confused now. Initial phase, there may be hypertension, but eventually there will be severe hypotension because of decreased systemic vascular resistance and diminished cardiac output. Both will ensure that there will be hypotension and collapse of the patient. Women who survive beyond these two first phases, they will invariably land up with consumptive coagulopathy. So again and again, I'm repeating, hypotension, hypoxia, and consumptive coagulopathy, H2C, is the problem of amniotic fluid embolism. Usually they have lung as well as brain injury. Brain injury is mainly because of hypoxia. Lung injury anyway, as we have seen, because of the vasoconstriction. The risk factors for the various thromboembolism, venous thromboembolism increase in blood coagulability. Pregnancy is a state of hypercoagulability, so it's a perfect backdrop for this coagulation problem. Then there can be venous stasis, especially if the patient has been taking bed rest for a long time. We prescribe bed rest in cases of placenta previa or maybe even preeclampsia. So that itself can be a problem. And after delivery, after cesarean, if they don't do early mobilization, there can be a problem. Trauma to the vessel wall. And these risks are heightened during pregnancy, particularly following cesarean section and puerperium. So I can say amniotic fluid carries dual risk of effects of embolism as well as hemorrhage as a consequence of DIC. So embolic, there can be minor problem like acute pulmonary distress or major problem, which is nothing but death. At the postmortem, embolic material is seen in the lungs, fetal squamous, vernix, laryngoshair, and meconium. Unfortunately, postmortem is the only confirmatory diagnosis of amniotic fluid embolism. Though it is very late, it is advisable in such cases of sudden death, we must, offer postmortem. Otherwise, the patients will never be convinced. They think that you have done something wrong. So if they refuse to accept postmortem, then you must take informed refusal signature. Otherwise, we can land up with problems. Hemorrhage, as far as hemorrhage is concerned, the mechanism of coagulation failure is uncertain, but it is usually consumptive coagulopathy. Hematological findings include depletion of fibrogen, that's what I said, consumption of fibrinogen, thrombocytopenia, again because of consumption, consumptive coagulopathy, that's what we say, and low levels of factors 5 and 7. So these are all utilized for coagulation initially, but that itself will be detrimental to the patient. And a variable degree of enhanced fibrinolytic activity as well as the formed clot also gets lysed, which is of no use later. These findings suggest that coagulation defect is primarily due to disseminated intravascular coagulation, otherwise consumptive coagulopathy. Now, clinical picture is not very difficult to guess. It is dramatic. Patient suddenly starts gasping, collapses. Nobody has a clue what happened. She had just delivered. Everything was fine. You are congratulating the parents or patient party. Suddenly, patient collapses in the labor room. So dramatic it is. Patient starts gasping for air in the late stages of labor. That should give you a hint, or immediately after the postpartum period. Seizures and cardiorespiratory arrest can occur. We all should be well versed with the immediate cardiopulmonary resuscitation. Massive hemorrhage will immediately supervene, and that's because of DIC. So these three things we have to always keep in mind. The signs and symptoms are varied, as I said, at times of quite subtle and include just respiratory distress, just a shortness or hardness of breath, hypertension, which may be not very severe, chest pain, fever, hypoxia, arrhythmia. Don't neglect any of these clinical picture. Timing of occurrence is very important. This is very, 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 very important. In fact, when I was an assistant professor, we lost one of our own staff nurses due to amniotic fluid embolism. We proved it by postmortem, and it was at that time patient ruptured the membrane spontaneously. So it can occur after the artificial rupture of membranes or spontaneous rupture of membranes associated with strong uterine contractions. Usually in the late stages, of course, after 10 centimeter dilatation, membranes have to rupture before the delivery. It could be at that time or even after cesarean section. So what do you see common here? Rupture of membranes, rupture of membranes, rupture of membranes. Whether it is artificial, spontaneous, or end of first stage rupture. It is rupture of membranes. Probably at that time, the air gushes inside and tries with a negative pressure due to the open sinuses. the amniotic fluid is pushed into the circulation. That's the only mechanical explanation that I can think of, but thankfully, it doesn't occur in a massive fashion in most of the ladies. But we have to be very careful whenever we do at least artificial rupture of membrane. Spontaneous rupture, at least patient will think that we have not done anything. But whenever we do artificial rupture of membranes, we have to be very careful. It has to be done with all precautions, and we should keep all resuscitative measures ready. Almost 50% of cases, there is a past history of asthma, urticaria, and hay fever. Generalized pleuritis, bronchospasm, hypotension, tachycardia within few minutes will occur. And there is usually respiratory distress, cyanosis, pulmonary edema, and retrosternal pain. There is acute collapse and shock, which is unmistakably amniotic fluid embolism. It could be other reasons. Cardiac arrest can occur, severe postpartum hemorrhage can occur, inversion can give rise to this. But if there's nothing, we have to think of amniotic fluid embolism. Coagulation failure, this may not develop until a few hours after embolism, but it is a feature virtually in all cases that survive at initial shock. Of course, the end point is sudden death, where before you think of anything, patient is no more. Of course, none of us can do anything at that very sad situation. How do you diagnose? As I said earlier, an irrefutable diagnosis cannot be established unless a careful postmortem examination is performed. Usually, it is a postmortem diagnosis. I have to take 2 more minutes. Amniotic fluid embolism should be considered in all cases of unexplained collapse, at least to prove that it was a case of amniotic fluid embolism. Clinical picture, as I've already given you, should point towards that. And blood coagulation studies will prove that, yes, there was DIC. They may die within a few minutes, if not, may develop angioneuritic edema, abdominal pain, and diarrhea. What is the treatment now? Yes, if you are lucky, if the patient is lucky, and if you recognize it very early, that patient is now going into severe hypotension and hypoxia and collapse, then immediate resuscitation is necessary to avoid high mortality rate. Treatment is mainly symptomatic. If you feel that there is hypotension, you have to give inotropics. If there is gasping, you have to intubate immediately. If there's coagulation, then we have to give anticoagulation therapy. And emergency care in a collapsed patient like CPR and shocked patient consists of immediate CPR, tracheal intubation, as I said, with oxygenation and ventilation, support of the failing myocardium by giving inotropic agent as well as the digoxin maybe, and circulatory support with rapid blood component and replacement to correct coagulation failure. So it is basically an emergency treatment. There is nothing much to think here. We have to immediately make sure that patient survives first, and then we can slowly take care of other things. Hydrocortisone in large doses is given intravenously. Aminophylline, in any anaphylactic reactions, we give aminophylline intravenously for the respiratory distress, and we have to correct the acid-base balance. It obviously means immediate care in the ICU or at least HDU. In undelivered women, it can occur in an undelivered woman also whenever there is spontaneous rupture of membranes. So undergoing cardiopulmonary resuscitation, consideration should be given to do emergency cesarean delivery. At that time, obviously, anesthetists will help us by intubating, by taking care of acid-base imbalance and other things. So outcome, if you are lucky, the patient may survive, the baby also may survive. In suspected amniotic fluid embolism, what treatment should be given? We must consider anticoagulant therapy. And it could be unfractionated heparin that acts very fast. It can be low molecular weight heparin, which may be long-acting. That is also given promising results. It is usually followed by oral fumarine derivatives. Placement of vena cava filter is one option where you cannot use heparin. And prognosis is in general poor in most cases for both. There is increased maternal and perinatal mortality. So that has to be kept in mind. There is one slide on air embolism. It may occur following clinical situations like when you try to put a catheter in the central venous pressure measurement, intravenous infusions as simple as that with a positive pressure, placental site in cases of abortion when you do suction evacuation, and air enters the right side of the heart first and gets into a froth there, and thus no blood enters the heart as it just compresses the froth. Probably at least 200 ml of air is needed to cause that. That's why luckily it doesn't occur every day. So what are the investigations to be done? ABG, radionuclide imaging, venous ultrasound, and pulmonary angiography. As far as the treatment goes, patient should be kept on the left side. Try to aspirate the air from the right ventricle so that the blood can move freely thereafter. So I'll end my talk with the algorithm for amniotic fluid embolism, AFE amniotic fluid embolism. If it is not there, if you don't suspect it, then initiate appropriate tests to rule out. And if it is suspected or if it is there, the next question to be asked is, are there any contraindications for anticoagulants? If there is a contraindication, as I said earlier, the only choice is inferior vena cava filter, because you cannot use anticoagulants. But if there are no contraindications, then you must check whether the patient is hemodynamically stable. If the patient is hemodynamically stable, then you have to see whether there is any contraindication to thrombolytic therapy. If there is no contraindication, then you can go ahead and give thrombolytic therapy, then of course anticoagulant therapy. If the patient is not stable hemodynamically, or if there is any contraindication for thrombolytic therapy, in both the situations, you have to consider IV unfractionated heparin, then switch over to oral anticoagulant therapy. So I hope I have dealt about the amniotic fluid embolism to the satisfaction of all of you.
Dr. Pai, that was really wonderful. I just wanted to ask one thing, that suppose there's a case of a patient suddenly develops cardiomyopathy. So how would you differentiate? Like in that, the prognosis is much better.
Yes, I agree with you. See, as I said, whether the collapse is due to cardiomyopathy, amniotic fluid embolism, or any other reason, the immediate treatment is an emergency treatment, which includes resuscitation, intubation, oxygenation. That once the patient is stabilized, then of course we go for echo and find out that this is a case of cardiomyopathy, where, as you said, the patient improves better. But even then, we have seen after discharge, suddenly patients develop problems and they have come, where we could revive them. So cardiomyopathy, which occurs in the postnatal period or immediate postpartum or during pregnancy, luckily is self-limiting and it goes. But if the patient has other reasons for cardiomyopathy, then it is difficult for report. But what I want to summarize is that we don't have to worry about what has caused this problem. The emergency treatment is that, we have to do resuscitation, emergency treatment, and think of anticoagulation therapy once the patient survives that. But unfortunately, in many cases of true amniotic fluid embolism, whatever theory class I have taken is not going to help. Patients suddenly collapse.
Really?
But what I want to really emphasize here is that please insist on postmortem to prove that it's a case of amniotic fluid embolism. At least nothing can be done, but at least we can save all other embarrassments and litigations that we have to go through, because nobody can accept, including us, that this kind of deaths.
True. Amita, there is a question by Dr. Achla Batra in the chat box. Just ask, sir.
AFE of two types, DIC and cardiorespiratory collapse. What is your opinion?
No, I said it is a continuum. It is not two types. There is a cardiorespiratory collapse that occurs, and once the patient survives, she will slip into DIC. We can't say this is first, that is second. They are all going simultaneously. It's a matter of time. It's a continuum. It's a spectrum. So we cannot say it is two types and all that. It is a part and parcel of the game. So if you remember my first slide, it is H2C, hypertension, hypoxia, and coagulopathy. They are together. Just a matter of time.
Lalita ma'am, please.
I think all of us.
Ranjana ma'am, I just wanted to ask.
Yes,
yeah, sure.
Thank you, sir. Thank you so much. I just wanted to know, can amniotic fluid embolism happen in second trimester?
Yes,
following
actually,
following
that's
an
what I
MTP.
said. Yes, that's what I have written in one of the clauses is an abortion. Any disruption to the placenta where the sinuses get opened, and there will be like a, see, second trimester abortion is almost like a mini labor. That's the
Yes.
difference. Only first trimester abortion is en masse abortion, whereas second trimester abortion, whichever method you use, is a mini labor, which means there is a rupture of membranes.
For
There's a
legal implications, I was asking.
yes, definitely. It can be. But again, whatever, whether it is first trimester, second trimester, third trimester, or cause death due to any reason, please offer postmortem. If the patient refuses, take signature that they have refused.
And second, is there any association of congenital malformed fetus and amniotic fluid embolism? Is fetus a culprit?
Congenital malformed fetus may work in an indirect way of through polyhydramnios.
Polyhydramnios. Yeah.
And
Indirect way.
misoprostol, role of misoprostol.
Yes, misoprostol. Anything that you beat the uterus will beat you through amniotic fluid embolism.
No, yes. And last, sir, I wanted to know, what are the echocardiographic findings in amniotic fluid embolism?
Yeah,
Right
if
heart
the
failure
patient
versus
survives,
a
if the
PTCM.
patient survives, then only we can think of all these things. Yes, there will be definitely some changes in the ECG, though I will not be able to elaborate. The cardiologist will be the best person to see minor changes. There will be ECG changes, but they will
Because
be
generally we are confused when we are standing by the side of the patient कि शायद patient को PPCM थी, हमने echo तो कराया नहीं, शायद collapse का reason PPCM है और शायद amniotic fluid embolism है.
These are all afterthoughts. And they are justified in putting up their theories. But the immediate action is only resuscitation and hoping for patient's survival. If the patient collapses without giving us any opportunity to save the patient, then it is amniotic fluid, cardiologist, pulmonologist, nobody can save
I know both are the same. Okay, thank you.
Because cardiomyopathy and this picture will present the same, but then the cardiologist will decide. I mean,
yes. If the patient survives, which means it must be mostly cardiomyopathy.
Yeah, true.
That was a very elaborate talk, and I think all of us are very clear regarding at least the presenting symptoms, the signs of the patient. And you have stressed repeatedly on the rupture of membranes, which was a very important thing. But quite a few times we go hurriedly, just take that thing and we rupture the membranes and wait for the labor to progress.
Nothing happens luckily most of the time.
Doctor, when we were PG students, we were told, especially in hydroamnios, that when you rupture the membrane, put your fist inside.
Yes,
and then gradually withdraw it slowly.
We do put 2 fingers, and in between you put needle. And slowly release the.
Or so we used to just put our fist inside and then release it gradually so that it does not come out as a gush.
Correct. Yes.
Another complication of ARM is cord prolapse in a high floating head, which we have faced times, and in that also you have to put your fist in, put the cord in place and transfer the patient in the same state to the OT for further action. But in this sad case, all these sad cases, before we know what's happening, the patient is gone. And it was very good of you to give us this very important point regarding postmortem. Because in the days of the legal proceedings which we face nowadays, we should have something on which we can stand in court in case we are taken to court for
even if they refuse, it is in favor of doctor.
Yes, that is very important.
Yes.
And the importance of managing a patient in case if we are lucky and if the patient is lucky in the initial stages. That was a very nice point which you told us about. But one thing is very, very obvious, that it is a multidisciplinary approach. We need a cardiologist, we need a pulmonologist, we need lots of people.
There's no doubt.
So
anesthetist. And we need an anesthetist for intubation. That is why Dr. Pai said it's better during cesarean.
That is one good thing, that when we do cesarean, it is a controlled environment where everybody is around us.
And thank you, Dr. Pai. I'm also a great admirer of your singing, which I have heard in the class. But I would love to hear it again if you have the time this time. Thank you so much.
I request all of you to go to my YouTube channel where I have posted many stuff.
That will be fine. Thank you.
Thank you so much, Dr. Pai, for accepting our invitation.
Anytime.
Thank you, sir, for such a lucid talk. And thank you, Chairperson Lalita ma'am, for summarizing it very well. And with this, I've hand over the session to my dear friend, Secretary of Allahabad Obstetrics and Gynecological Society, Dr. Jaiswal, to conduct the last session. That is again a very important topic.
Thank you, Dr. Amita. First of all, thank you, Ranjana ma'am and Amita, for giving me this opportunity. After a very enlightened talk by Dr. Pai, there's a dreaded complication of obstetrics leading to 100%, almost 100% mortality. We are moving towards our last session of the day, the role of routine episiotomy in primary para. The speaker is Dr. Bharti Joshi, the first chairperson amongst us, and Dr. Pooja Sikka, Professor, Department of Obst and Gynecology, Postgraduate Institute of Medical Education and Research, Chandigarh. Her area of interest is high-risk pregnancy and medico-legal disorder, medico-surgical disorders, maternal, near-miss and gynecological health of women. The another chairperson is our dear friend, Dr. Ritu Sinha. She is past secretary, Allahabad Obst and Gynae Society, 21-22. She is senior consultant, Department of Obst and Gynae, Dwarika Hospital, Prayagraj. She is ex-treasurer. She is member of many organizing committee, ICOG 2020, UPCon, FOGSI BOH, SEVMA. She is editor of Souvenir, UPNCon and SEVMA 12. She is trained gynecological endoscopy at AIMS, Delhi. She has published article in International Journal of Clinical.
Thank you, Dr. Uma.
Aage karo.
Now I request Dr. Ritu to introduce our speaker, Dr. Bharti Joshi.
Thank you, Dr. Uma, for this kind introduction. Now, before starting the session, I just pay my sincere thanks to Dr. Khanna ma'am for having given me this opportunity, and my sincere regards to all the senior faculties on board. Now, coming back to the session, we all agree that an episiotomy do prevent serious tears during childbirth, but whether it should be a selective one or a routine episiotomy, it is a matter to ponder over. So in this era of evidence-based practice, let us hear from Dr. Bharti Joshi, who is the eminent speaker today. She is an assistant professor in PGI Chandigarh, and Dr. Bharti is a brilliant scholar throughout, and she has received first order award as silver medal for MD PGI MER Chandigarh. She has been the joint secretary of North Zone Yuva FOGSI in 2020 and has worked as COVID-19 nodal officer and received a very prestigious award from UT Governor for her commendable work. With special interest in the field of infertility, endoscopy, and high-risk pregnancy, she has 40 research publications in her name. I welcome Dr. Bharti Joshi, and I request her to please start her deliberation. Dr. Bharti Joshi, over to you.
Yes. Good evening. Am I audible?
Yeah, you are.
Yeah. Thank you, organizers. Thank you, Dr. Ritu, for your kind introduction. So I'm going to share my screen first. Is it visible to all?
Yeah, it is.
Okay. So I have given a talk to say about episiotomy in primary para, whether it should be a restrictive one or it should be the for all. Whenever there is a talk about any obstetrical intervention, we need to think of in terms of whether it is beneficial for mother or it is beneficial for baby or it is beneficial for the both. So let us see and trace the journey of episiotomy, that how it came and where it stands in today's era. Episiotomy is the most common obstetrical intervention till date which is being practiced by all of us. We think that it is a surgical planned incision on the perineum and the posterior vaginal wall. We give it during the second stage of the labor, especially for all the primary paras in most of the institutions. And it is compared to a second degree perineal injury as per the anatomical types. So these are the types of episiotomy which is being practiced day-to-day life. And if we look at its prevalence and risk factors, the first episiotomy was reported in 1741. The worldwide rate of episiotomy after that dramatically increased because everybody said that it is too beneficial, it has to be given for all. And after 1920, when D. Lee advocated for its use, and institutional deliveries simultaneously was on the peak in US around the same time. But let us see what happened next. By 1930s, most of the obstetrical standard books, they endorsed the procedure. They said episiotomy for all, arguing that it is a proactive cutting that may prevent the extensive tearing. But gradually something happened, or what went wrong. After 1983, when there was a 69% of vaginal deliveries rate in US, it significantly dropped to 19.4% in 2000 and further lower down to 5.2% by 2020 in US. This was not the scenario in US. There was a hospital survey by Leo Frog in 2020, and they have found that in most of the countries, the average rate of episiotomy across teaching hospitals was 4.7% as compared to 6.1% in non-teaching hospitals. So look at the journey of this obstetrical intervention, where it was proposed for all. It was nearly 80-90%, then came to 70%, and now in most of the countries it has been reported between 4 to 7%. So seeing all these global scenarios, WHO stated that around 10% threshold for episiotomy in an institute is a good goal to pursue. So any one of us, if giving a audit, doing a auditing and saying that we have a nearly 10% of episiotomy rate, that is being justified by the WHO. So moving to the further, looking at the Indian scenario, probably we don't have that much catching scenario as compared to rest of the countries, because there is a data published recently, and they have basically determined the trends and determinants of use of episiotomy in a population-based registry from central India, where they have found that between 2014 to 2018, there was an increase in episiotomy rate that was from 13 to 31%. However, this data, when was compared from 2004 Indian data, this data was lower because at that time it was reported at around 45%. So looking all this, what has happened? WHO has said that what went wrong in between? Probably WHO felt that there is a humanization of the childbirth in 2018, because all of us has probably lost a personal touch with the patient. There will be more of a medicalization. For every delivery, we want to augment the delivery, we want to give some kind of special treatment or special medications. There was in between obstetrical violence scenarios, and most of the time now, previously it used to be a patient-centered approach, but now it has turned to a doctor-centered approach. So WHO in 2018 came with recommendations saying that you have to give a intrapartum care for a positive childbirth experience, to give a respect and dignity, a companion of choice, clear communications, and pain relief strategies. And what it said that there are few set of recommendations, and these set of recommendations are from 17 Cochrane reviews, incorporating that what kind of obstetrical intervention we were doing previously, whether it is truly needed in present scenario or not. So it was totally revised by evidence-based guidelines, and episiotomy was also talked about in this guideline. So let us say, what was the take of WHO on this? WHO said that many interventions, like we were giving enema, we were doing shaving, we were giving antibiotics, we were doing amniotomy, elective amniotomy, and we were giving episiotomy. So WHO said that many interventions earlier considered to be effective are harmful, or even if they are not harmful, they are not beneficial. And some interventions which are not routinely practiced, like we are not opting for a different birthing positions, like we are not talking about liberal analgesia to the patient, so they have a major role. So WHO wants us to make a shift from the obstetrical interventions which were considered effective previously, but now they are not beneficial, to move on to the interventions which are not being practiced as such in routine, because it has been found that these interventions probably are going to prevent maternal and perinatal mortality as well as the morbidity. So why WHO thought of about episiotomy and to state that it is not indicated for all, it advised against routine or liberal use of episiotomy for women undergoing spontaneous vaginal delivery, because it was said that there is an unclear goal rate. In US, we are saying that 4% is okay. In India, we are seeing a rate of 27%, even 40%, and WHO saying that even 10% is okay. And another important thing, that indications till dates are not clear, because for one patient, there can be a same scenario, can be an indication for the episiotomy, but in another patient, the same scenario cannot be an indication for the episiotomy. And an acceptable rate of episiotomy was definitely, it was difficult to determine because there were so intercurrent variations, and role of episiotomy in selective cases was to be identified. So these were the one recommendation which came, that is a 39 recommendation saying that routine and liberal use of episiotomy is not recommended for women who are undergoing spontaneous vaginal birth. So reasons why we thought of giving an episiotomy in beginning, ethos behind. So let us see why we thought, what are the benefits we thought in mind, and why WHO is contraindicating all these benefits. We thought that it is going to augment our difficult vaginal deliveries. It is going to provide some kind of perineal space, and probably it is going to lessen the perineal injuries. And similarly, if we give a planned incision, it will be easy of repair, and it will improve wound healing, and it will provide a kind of pelvic floor support, and thus reducing the risk of urinary incontinence and pelvic floor dysfunctions. And it was not like that it is giving the benefit only for these situations. They also said that we are getting benefits in certain situations, like reduction of trauma to the fetal head. Whenever a premature fetal head passes through the birth canal, if we give a episiotomy, it has been advocated to minimize the risk of intraventricular hemorrhage in preterm births. And similarly, there was a benefit of prevention of shoulder dystocia, but later on, many evidences came, and probably they were against all these situations. So at present, even if you look at the scenario, probably we feel that still episiotomy is in our blood, and it is a routine component of deliveries, at least first delivery, with aim of avoiding injury to the posterior perineum. But whenever there is any obstetrical intervention or any kind of intervention, it is not without side effects. Some may have a less side effects, some may have a more. So let us see. We believed that episiotomy is going to give us a lot of benefit, but probably we were wrong in that, because episiotomy is a harmless procedure was a belief, because it carries a number of risks. Many patients, we see that it causes more blood loss, and that blood loss compared to the females who don't get the episiotomy is seen to be in terms of more than 300 ml. And vulval hematoma, probably we have seen that sometimes that apex is not well taken, and many patients, they present to you with the vulval hematomas and late complications of all these vulval hematomas. In patient of thrombocytopenia, we frequently see after episiotomy there are vulval hematomas. And another important thing, although we give a planned surgically cleaned incision, still the wound rate infection is 0.5 to 3%. That is said to be in ideal conditions. In other conditions, they reported it up to even to 10%. And more suturing is needed. Prolonged pain and dyspareunia, that is seen in 10 to 20% of cases, and sometimes there is a psychological trauma also. So these were the side effects which they found over a period of time after giving a routine episiotomy to the all women. They also saw that extension of the incision could be there, leading to 3rd and 4th degree perineal tears, particularly for median episiotomy. And there was a risk of unsatisfactory anatomical results, because sometimes females coming to us after 6 months or even 1 year of normal delivery, they say, Doc, I feel some kind of tightness in my vagina, because you can see some kind of skin tags. There can be asymmetry of the vagina. There can be sometimes fistulous formation if there is a failure to identify a 3rd or 4th degree extension of the episiotomy. And there can be narrowing of the introitus and increased risk of perineal lacerations in subsequent deliveries, not in present, but again in next delivery, there is increased chances of severe perineal lacerations. So these were the side effects which were seen with the normal routine episiotomy. Apart from that, there were a literature coming up that what about perineal tears? We were saying that yes, it is going to prevent probably perineal tear. If we don't give episiotomy, patient will have a perineal tear. But the literature came against that. Literature said that compared to the hospitals where episiotomy use is less, in hospitals with strict policy for routine episiotomy, 3rd and 4th degree tears are common. So it means we were thinking in terms of that by giving the episiotomy, probably we are going to avoid unplanned tears. But the report evidence came against this, saying that when we give episiotomy, the tears of 3rd and 4th degrees are common in females who receive episiotomy as compared to who didn't have episiotomy. Deep tears are usually extension of episiotomy, and 14% of all, they have a kind of perineal tears, and they'll be more of posterior perineal trauma. But a woman without episiotomy likely to have no tear. But if even they have a tear, the tear will be more of a primary or secondary degree, and they hardly suffer any deep tears. So literature was now saying, because episiotomy probably provide a way to more extension of the already given incision. So there was a prospective observational study that reported that episiotomy was associated with a 3 centimeter long perineal laceration compared with no episiotomy. And 80% of the episiotomies were midline. In a meta-analysis of 22 studies also, midline episiotomy, even they found to have more obstetrical anal sphincter injuries. And in addition to the risk of anal incontinence, obstetrical anal sphincter injuries have been associated with postponed coital onset and dyspareunia 1 year postpartum. So what about, we have talked about perineal injuries, that probably episiotomy is not going to give us benefit in terms of perineal lacerations. Probably it is going to aggravate the types of 3 and 4th. And the same thing came about the pelvic floor functioning, because in episiotomy, it was thought that it will strengthen the pelvic floor muscle and patient will have a less chances of prolapse. She will have a more tightened vagina after some time after giving episiotomy. But what the evidence came that in women without episiotomy, better pelvic floor functioning at 3 months was seen, and there was no increase in prolapse and urinary incontinence, and she can have the continued sexual function even after birth. But the women who received and who underwent episiotomy had more painful intercourse after 12 to 18 months after birth. And because they had a 3rd or 4th degree lacerations, they can have a more pelvic floor dysfunction such as incontinence and prolapse. And symptoms vary also with the repair technique, but more data will be needed for the further conclusions. Similarly, there was evidence which was compared regarding urinary and fecal incontinence, whether it was more after giving episiotomy or it was more after not giving episiotomy. So there was a systematic review in 2005 that concluded that routine use of episiotomy conferred no benefit for prevention of incontinence and potentially caused some harm. But other literature reported lower anal incontinence prevalence rates at 4 years postpartum in the restrictive group. So rethinking of benefits, we need to think of the benefits. We have seen that it is not without side effects, but what we thought that it is going to give the benefit, we need to think of about these benefits again, because we talked about that it is going to reduce the trauma to the fetal head. But there are enough literature now came up that giving the episiotomy is not going to prevent peri-intraventricular hemorrhage of a preterm. The other interventions which are effective for preventing peri-intraventricular hemorrhage of any preterm birth, they are giving antenatal steroids, giving antenatal Maxelf, giving CPAP after birth. But we were saying previously that it is going to prevent any kind of hemorrhage in preterm, that is not evidence-proved. So there is no intervention in terms of episiotomy which is going to help us to prevent this severe morbid condition of the neonate. Similarly, prevention of shoulder dystocia, we talked about probably. While episiotomy does not appear to prevent shoulder dystocia, its use in the management of shoulder dystocia is still less clear because we didn't find significant control trials or observational studies commenting specific about that. Similarly, we talked about preservation of the muscular and facial support of the pelvic floor. It neither protect pelvic floor strength or may result in a weakened pelvic floor musculature when compared to spontaneous laceration, because if we give a planned incision, there will be more kind of fibrosis, and whenever there is already a muscle fibers, probably they are going to gain their tensile strength after some time. But if these muscle fibers have been replaced by the fibrosis, probably they are not going to retain the tensile strength. So how this can be extrapolated in this way. So routine versus restrictive episiotomy, we need to have search for the consensus, and let us say what Cochrane is saying about this in 2017 review. So what Cochrane has done a meta-analysis of 12 trials that comprised around 6,177 women expecting an unassisted vaginal birth. Restricted episiotomy resulted in up to 30% fewer women sustaining severe perineal or vaginal trauma. So they found that where we chose that the women who need episiotomy has to be selected by the clinicians or depending upon the condition of the female. In that, the 30% fewer women have a severe perineal or vaginal trauma, and no differences between the groups in postpartum day 3 perineal pain, long-term dyspareunia, urinary incontinence, and genital prolapse was seen in 2 groups. Both selective and routine episiotomy have little or no effect on the infants with Apgar score less than 7 at 5 minutes. It means the neonatal outcome is same in both groups, and there may be a little or no difference in perineal infection in both groups. There is probably little or no difference in long-term dyspareunia also, and there is a little or no difference for long-term urinary incontinence. So to conclude by this, Cochrane said in women, where no instrumental delivery is intended, selective episiotomy policies result in fewer women with severe perineal or vaginal trauma, and other findings, both in the short or long term, provide no clear evidence that selective episiotomy policies result in harm to the mother or baby. So when to consider episiotomy? Now from all the discussion, at least it is clear that it should not be for all, because what benefit we thought of gaining by giving the episiotomy? The evidence has proven that it is not going to give us so much of benefit, which was reported earlier. So they say it has to be restricted to the patients, and it has to be on the discretion of the delivering clinician, and we need to judge the clinical scenario at the time of the delivery. So at least we cannot say that this is a specific situation where episiotomy is essential, but we can go by the clinical scenario and by the discretion of the delivering clinician. So where we feel that we need to expedite the delivery of the fetus, like a category 3 or pathological CDG, or operative vaginal delivery, although multiple societies advise against routine episiotomy with operative vaginal delivery, but they still say if it is indicated, go for the mediolateral episiotomy. And when the clinical circumstances place the patient at high risk of 3rd or 4th degree laceration, or other conditions like short rigid perineum, face to pubic delivery, and vaginal breech delivery. So ICOG recommends that mediolateral episiotomy should be considered in instrumental deliveries, as it may have a protective effect. The best maternal outcome of a pregnancy is a normal vaginal delivery with an intact perineum, because we see that there is an increase up to 300 ml or more blood loss among the women undergoing episiotomy. So this is again about the mediolateral and lateral episiotomy and recommendations by the various systematic review and meta-analysis favoring that this is the better modality of episiotomy as given the median episiotomies, and the procedure what we need to select mediolateral is being preferred by WHO, ICOG, ACOG, all recommends. And what they say that patient has to be truly informed. It can be a verbal consent, but that has to be there. And truly informed consent during labor and potentially urgent obstetrical care may be challenging to obtain. So ideal information about all these procedures has to be started from her antenatal or prenatal care. And it is not that giving the episiotomy, our job is done at this pregnancy. No, when a patient comes next time with who had an episiotomy in the last pregnancy, she can have impact on the future deliveries in terms that at the time of first vaginal delivery, it appears to increase the risk of severe obstetrical laceration in a subsequent vaginal delivery. So even if at present scenario in India, we are talking about achieving Lakshya, where the focus is to reduce mortality and morbidity. So again, we need to target about this morbidity and this morbidity by lowering the rate of our episiotomy, and secondary to enhance satisfaction of beneficiaries through RMC. So to conclude, we can say that episiotomy to be performed on an individualized basis, and we need to audit our records periodically. Like this will help us to know that what scenario led to more increase in the episiotomies, or it was a patient profile, or it was a clinician judgment, and this will help us to keep a check on the rate of episiotomy in a particular scenario, in a particular hospitals, and counseling from the antenatal period, and management, judicious management of the complications even related to episiotomy is needed. So I close my presentation by this Cochrane wording saying that one should always assume that a treatment is ineffective unless there is evidence to the contrary. Thank you so much.
That was a wonderful talk, Dr. Bharti. And Dr. Pooja, I would like you to give your comments.
Thank
Hello,
you so
ma'am.
much. Thank you so much. It was an enlightening presentation, very crisp presentation, but it can and it has raised many questions. So what I understand is that it has to be a clinical situation based.
Clinical situation based.
Decision
and-
whether to perform an episiotomy or not.
Yes.
So we will start with first question. Suppose
ma'am.
in your hospital, a severe MS
Yes, ma'am.
is induced at
Yes.
37 weeks for cholestasis of pregnancy. So what
Okay.
will you tell, what should we tell our residents? Episiotomy, dena ki nahi dena? Basically what I want to know is, does it shorten the second stage of labor? We have understood that there are many disadvantages of doing or performing an episiotomy. But what is the main advantage of performing an episiotomy? What does
Ma'am,
it do?
Main advantage of
Bharti, could you stop sharing?
yes. Yes.
Yeah.
Ma'am, first I should
Bharti,
answer.
you have made us understand everything, but just clinical
Just a-
situation based.
Yes. So yes, they say when they have compared a second stage delivery time by giving the episiotomy to a particular patient or not giving to a particular patient, yes, it has reduced the time, but that time was in terms of 2 to 3 minutes gain only. So they say when you really want to have that gain in that particular patient, so that time gain is required for a particular set of patients where we feel either it is a kind of patients where we need to expedite the delivery because fetus is having a distress. A second stage patient.
So 2-3 minutes is never for mother.
Ma'am, 2-3 minutes for a normal, uncomplicated mother is never matters when we can say second stage can last for 3 hours.
Yes,
Then
and
how
for
it is
a
going
mother
to-
with a heart disease?
Ma'am, for a mother, definitely we have to, we always say that we need to cut short of the second stage of the labor, right?
So does it help?
Whenever we talk about cut stage of the second stage of the labor, even we think for these mothers applying instruments, because second stage cutting, most of the time we do by putting the forceps or putting the vacuums. And ICOG do say that whenever you apply forceps, you give mediolateral episiotomy because this is help to prevent the trauma to the mother. So for instruments, whenever we are thinking, I think for this patient, if we are thinking of shorting the stage, definitely a episiotomy will be justified for giving this patient.
And second thing, how do you reduce the obstetrician's anxiety? Because we said what we have learned is it is a clinical situation based. Clinical situation may it is the patient, it is the fetus, and it is the obstetrician. I stand before the patient. I feel this was a very hard time for the patient. 12 hours, 14 hours. Hi, patient को बहुत pain हो रहा है. I am standing, I am waiting. छोटा सा perineal tissue की जो blockage है, जो obstruction है, इसको तो release करो, फिर देखेंगे. So how do you reduce the obstetrician's anxiety?
Then that
To reduce my anxiety.
That obstetrician anxiety has to be reduced first from the uncomplicated patients. What we personally feel, we are giving episiotomy even for the multis, where you feel that it will come out like this, it will slips into your hand. We have that reflex in mind that we will put an incision into that patient. I think that reflex has first to go. We should not start our practice from a patient who is primary with a rigid or pre-eclampsia patient, even talking about I think we need to start from the patients who are multi, where we feel that yes, it will come, she has a lax vagina. Even in that multi patients, we are giving episiotomy. So our practice should begin from that. So probably that is going to provide us some kind of confidence, and that confidence can later be transpolated.
So basically it is not a doctor-centered treatment. It is
should not be
patient-based.
It should, every approach should be by WHO a patient-centered approach, जिसमें morbidity भी कम करनी है लक्ष्य के हिसाब से, और patient को भी बात करने के लिए हर patient को काट के. We see so many complications, ma'am. Thrombocytopenia का vulval hematomas हम drain कर चुके हैं, 3rd, 4th degree perineal tears, हम fissulas हम देख चुके हैं. We see so many complications with episiotomies. And
But then Bharti, if there is a rigid sort of a perineum,
yes,
and if it doesn't seem to be giving way, then it's better to give a clean episiotomy than to have a bad tear.
Yes.
Ma'am, that is recommended. That is recommended in restrictive, where if it is a rigid perineum, you give episiotomy. That is an indication of a restrictive episiotomy.
Yeah.
They have a clear-cut indication that instrumentation you give,
Yes.
restrictive perineum you give. Even we talked about MS patient, we wish to cut short. Definitely, it is going to lessen your tooth.
I remember years back when I was doing my post-graduation, we were strictly, and I was a house and that was around 1979. We were strictly told that you must give an episiotomy in primary. And once I remember I was delivering another patient in the other room, and this patient, the baby came out smoothly and there was no tear, nothing. But because of fear that I'll be scolded tomorrow that where's the episiotomy, I give a small nick. So the patient is asking me, ma'am, humko kata kyo? So I said, नहीं कटा नहीं, वो थोड़ा सा कट ही गया था, अब उसको सिलने जा रहे हैं.
Actually, this reflex has to come naturally in our mind.
But now, of course, we try to deliver as much as possible without episiotomy. But whenever I feel that this tissue is quite resistant, then I will always go in for a clean episiotomy rather than a bad tear.
So that is an indication where you feel it is rigid, not giving way. So it is an indication. Ma'am, it is similar to fundal pressure, right? Most of the time we are giving fundal pressure, but WHO is saying not fundal pressure, and we say कि कैसे आएगा बच्चा, but बच्चा
right.
Scenario है. The episiotomy का भी वही scenario है actually. कि जब US Canada में 4-5% हो सकता है मैम, तो कुछ ना कुछ तो Indian problem है, because mother profile तो वहाँ पे तो ज़्यादा मतलब उस हिसाब से है ना हर चीज. तो 4-5% and 31% is a huge difference. In our scenario, so even PGI we have little more rate as compared to.
Very nice to
60%, Bharti.
हाँ मैम ज्यादा है.
Episiotomy rate is 50-60%.
50-60% है हमारा, और हम तो justify करते हैं कि we always get complicated patients. Pre-eclampsia हो गया, preterm हो गया, heart diseases आ गई, kidney disease आ गई.
Fundal pressure तो लोग रिपोर्ट ही नहीं करते. एपिजियोटमी तो पता ही चल जाती है, फंडल प्रेशर तो लोग रिपोर्ट ही नहीं करते.
मैम इम्पोर्टेंट ये है कि ऑडिटिंग अगर होती रहे ना पर मंथ भी, तो आपको 100% यू विल कीप. ऑडिटिंग इज वेरी वेरी इंपॉर्टेंट एक्चुअली.
वेरी इंपॉर्टेंट.
हाँ, कि किस पेशेंट में आपने क्यों दिया, मतलब दैट इज द इम्पोर्टेंट थिंग. सो दैट इज गोइंग टू हेल्प अस, आई थिंक.
It was a great pleasure to meet Dr. Bharti, Dr. Pooja, Reeti. I met in Pune, and that's how I came to know about details about you all people. And Pooja, I loved the way you frame your questions. You are very cool and confident, and typically like a teacher you would expect to be. A teacher is expected to be like her. So it was real pleasure meeting both of you.
Thank you.
And Bharti, your talk was just about perfect.
Thank you, ma'am. Thank you so much. Thank you, everyone. Thank you.
Thank you. So I think there is
speakers.
Are there any questions?
Dr. Pooja, Dr. Ritu, and faculty is on board. We have completed our last session. The talk was very elaborate, very excellent. We have individualized the case for episiotomy. If any instrumental delivery, we have to cut short the second stage. We give episiotomy, otherwise not. Thank you very much. Thank you, Ranjana ma'am. Thank you, Amita, for giving me this opportunity. Thank you.
So, thank you. And after this wonderful academic feast, the time has come for formal vote of thanks. My sincere gratitude to Obstetrics and Gynecological Society of Northern India and Allahabad Obstetrics and Gynecological Society for holding our hands. I can't thank enough the ICOG office for always granting us points. My utmost thanks to our chief guest, Dr. President-elect Dr. Jaydeep sir, for her gracious presence and his blessings. My gratitude to our chairpersons, Dr. Reeti Mehra, Dr. Manisha Goyal, Dr. Lalita Shukla, Dr. Ritu Sinha, Dr. Pooja Sikto for your presence and your valuable inputs. My thanks to our speakers, firstly Ranjana Khanna ma'am for her wonderful talk as always, and her guidance and leading from front. Thank you so much, ma'am. Listening to Dr. Mullidhar Pai sir is always so gratifying and always gives us many things as a take-home message. Dr. Bharti, your talk was such lucid, and we have learned so many things today. Thank you so much. Special thanks to my co-conveners, Dr. Uma and Dr. Parul, for assisting me in this task. And sincere thanks to Jagsonpal, especially to Dr. Deepika and Amit, for always helping us for technical support and everything. Because of you, these webinars are so smooth, and we don't have to worry so much about what will happen during the transmission and all that. Thank you so much. And last but not the least, to all the delegates who have joined for this webinar.
ICOG.
ICOG. I have, ma'am, बोल दिया मैम. शुरू में बोल दिया. ICOG का बोला. Thank you so much.
I take this opportunity to request for our few brands in API and indigenous formulation Divatrone, an edge over other brands, has won the Evox Marketing Excellence Award last year. All because of the support. Maintane is our product, HPC, 250 and 500 mg injections. And Verena, nanosilver vaginal gel, especially for episiotomies. I thought that probably I should put it and showcase it today. So thank you. Next, we have another infertility webinar, that is Indian Fertility Society, which is on endoscopy, basically, SIG endoscopy. So do join us this Saturday. Thank you all.
Today we completed
before time. Today we have
I know.
Before time.
Today we started bang on and then continued at top speed.
Yeah, 6 minutes before.
Yeah.
That is a good
My case at 6:30.
Congratulations to everyone.
Thank you.
For being very time was perfect today. Yeah.